Dr. Sunil will be just joining us. Gaurav, Dr. Sunil is joining.
ज्वाइन कर रहे हैं, लॉग ऑफ करके दोबारा ज्वाइन कर रहे हैं, कुछ इशू आ रहा है।
अच्छा, he'll be just joining actually. In the meantime, more people may also join in the attendees. Dr. Sunil is back online. Dr. Sunil, can you hear me?
Yes, sir. Can I?
Now?
Am I audible, sir?
Yeah. How are
Yeah.
you?
Yes, sir. Fine,
Nice
sir.
to see you
Good
after a
evening.
long time.
Yes, sir. Same here.
He has maintained his smartness. He was always a smart person. I introduced you to the all the participants and
Okay, sir.
told you आपके secret भी बता दिए मैंने.
Sir. So nice of you. So it's always
That-
nostalgic, sir. It's
yeah.
always
So in the
nostalgic.
meantime, when you were just logging in, I introduced the all the your achievements and everything. And it's really great to see you achieving so heights.
Yes, sir. It's always it's my pleasure to be a part of Gangaram always. I have learned a lot from there, and all this is because of the hard work we have done. Almost, I know that is the one of the reason, but the platform which has been provided by Gangaram is non-matchable. We can just imagine those old days only, that we has to used to work all day and night because the number of residents were very less. Although this is not the same situation nowadays, but of course the situation must be better for the residents. But I think uh, Gangaram is the one of the best place where we can work, and I can't say more than that. So shall I start, sir?
Dr. Sunil, you can start directly.
Okay, sir.
Make it full screen on your part.
Yeah, I will, sir. So a big thanks again from the Gangaram and the IAP Delhi for just it's consecutive my second presentation for the past 1 month or so. And I am deeply attached to DNVs also, sir. यहाँ भी I am used to train them, and we are having a good number of DNVs who has passed now. So it's ongoing process till now.
Good.
So yeah, okay. So today we are just going to start about just a minute, sir. Minimize name, right? Okay. Yeah, it's fine now. So today we are just next 45 minutes or so, we are just going to have a brief discussion about clinical approach to pneumonia in children. This is not just a textbook teaching. We are just going to have few slides on this, but it's more practical things we are going to discuss. So the practical things one comes to mind when a child with fever, tachypnea, and respiratory distress or more also comes in the OPD or in the emergency room, then the first thing is that should we admit this child? What are the investigation we should do and how we will proceed? So this is the thing we have to just keep in mind. And then we have to proceed. So it's one of the common presentation in the pediatric population. And nowadays we have seen many cases of pneumonia in children. They can be viral pneumonia, they can be, some of them can be recurrent, some of them can be persistent. So we are going to have a brief discussion about that also. So this is my hospital. We will not go in detail of this. We are mother and child, and right now we are 150 beds. So coming to the case one. So this is all we are going to discuss is case based only. And then we will discuss about that what are the things we can do in a simple manner, in a phased manner, and what are the implications of those diagnostic modalities we are just going to have, and how they can improve the diagnostic acumen. So this is a 3-year-old presented with a history of fever and cough for the past 3 days. On examination, respiratory rate is 56 per minute. This is very important. There is no chest indrawing. Saturation is around 94% and feeding is adequate. So this is one of the common scenario nowadays. So what is the next step at this stage? First, should we start the antibiotics? Second, observe and symptomatic treatment. Third, we will order an X-ray. Fourth, admit. So these are the common things we just come across. So again, a 3-year-old presented with this is the again, I'm just repeating. So on these findings, does this child have pneumonia clinically? Having fever and cough for the 3 days. Tachypnea is there. There is no chest indrawing. Saturation is 94% and feeding adequate. So the first thing comes is, so now this is about the WHO classification of the pneumonia. Previously, classification and treatment of childhood pneumonia, we were describing about 2 months to 59 months of age. And the child is having with cough and difficult breathing. So initially, we used to have no pneumonia, pneumonia, severe pneumonia, and very severe pneumonia. So it was quite complicated. Cough and cold, no pneumonia, and then fast breathing pneumonia, we used to treat with the oral cotrimoxazole. And the child having severe pneumonia with chest indrawing, subcostal, intercostal, and danger signs along with that, then very severe pneumonia. What are those danger signs? Having cyanosis, having difficulty in speaking, or diaphoresis, or bradypnea is there. So these were the signs of the danger sign. Now, since we are dealing with the developing nation, so there are many peripheral centers are there. So they have to be very cautious about that things should be simple, just like BLS. So they have just summarized it: cough and cold, no pneumonia, and then chest indrawing is pneumonia. And home care or amoxicillin for the fast breathing, and for the severe pneumonia or very severe, they have just classified as only 2 entities now. Either this is pneumonia or this is severe pneumonia. They have removed the very severe pneumonia in this condition. So only 2 diagnoses are left: pneumonia and severe pneumonia. Okay. So coming again to the case. So in we can just recapitulate the respiratory rate findings. Less than 2 months, 60 or more, we call that pneumonia. 2 months to 12 months, 50, and 12 months to 5 years, 40 or more. So at any age of time in pediatric population, above 5 years, 40 is the cutoff value. So, and just to remember it, we can just simplify also it. So bradypnea is less than 60 and tachypnea is more than 60 at any age. So, and respirator should be counted for 1 minute. So this child has a respirator rate of 56 minutes and fits into the third category. So of course, this child has pneumonia. So what are the non-infectious mimics of the community acquired pneumonia? So in cardiovascular, neoplastic, these are the few lists which can be presented, but out of these we have to just more common in adult population. In mimics, generally in community acquired pneumonia, we just come across commonest are bronchiolitis, asthma, then maybe pulmonary tumors are one of the findings, and then less commonly can be SLE, eosinophilic pneumonia, Wagner's, etc. Now comes the diagnosis of pneumonia, why they have chosen tachypnea, and then second finding is chest indrawing. So sensitivity of around tachypnea is around 60%. So the combination of the findings is more appropriate for the diagnosis of the pneumonia. So specific tool, tachypnea sensitive and specific tool has approximately 62% and is better than auscultation, because in auscultation we just, if we look after the pediatric advanced life support, now we call it as IAP ALS, Indian Academy of Pediatric Advanced Life Support. In India, we just follow those only. So they say if the pneumonia is there or the respiratory insufficiency is there, then they have respiratory distress and respiratory failure, impending respiratory failure, they have removed again. Then second thing is that they just classify based on that upper respiratory involvement, lower respiratory involvement. If group is there, they say at upper respiratory involvement, then the lower respiratory parenchymal disease, and then asthma and pneumonia. So all those wheezing and crafts, they can be misleading sometimes, but even in the bronchiolitis, we can see the crafts, we can see the wheezing as such. So the tachypnea is sensitive tool and maybe specific, but very sensitive. And but when we are dealing with the general population, then they are very effective tool, and they can be used as a beginning step, as a triage only. So the crux is that we have to use all the clinical skill for the final diagnosis. So now coming to this case. So now we can see that this case has tachypnea. Now the question comes, how to differentiate between the viral pneumonia and the bacterial pneumonia, or the viral only with acute febrile illness or viral etiology of the acute respiratory tract infection, or the bacterial. So all things well taken that they have more fever in bacterial, then the child looks more sick in the bacterial. They are, of course, they are differentiating factors, but in OPD practice, what we have seen and what is recommended is that the prodrome is one of the most important thing which can differentiate between the uh, viral and the bacterial. So if your child is having sneezing, watering of the eyes, and coryza is there, so that goes more in favor of the viral prodrome, viral illness rather than the bacterial. One thing. And then, of course, if the child is coming late, then non-resolution of the symptoms beyond 4 or 5 days again goes in more in favor of the bacterial. This is before the diagnostic tools. So fever and cough for the past 3 days again. So now question arises. This child is having bilateral wheeze, saturation is good, child is feeding adequately. So do we like to start antibiotics this child? So now this child is having isolated tachypnea with no chest indrawing. Saturation 94% is acceptable. Less than 92% is supposed to be the alarming sign. And child is adequately fitting. So this signifies that this child is having non-severe low respiratory illness, but not necessarily the bacterial. This is in for sure. So the important key consideration is tertiary care is we see this as an isolated tachypnea, and we have not to be hurry about the starting the antibiotic. So a significant proportion of such children, they have the viral infections, bronchiolitis, viral LRTI, where antibiotics offers no benefit. So in this child, in this case, of course, no upfront antibiotics are required. So this clearly fits in the case of community acquired viral illness, community acquired pneumonia. We can't deny it as per the WHO definition, but this is not the severe pneumonia, and child can be sent home with just precautionary measures. So in OPD treatment, we have to just write that this child has these symptoms, so it fits in the care. So diagnosis, three things has to be mentioned in the OPD: sleep or the emergency sleep, that these vitals first, then there should be a diagnosis. So vitals we have written, then the diagnosis is pneumonia and non-severe pneumonia or pneumonia, and child is accepting well. So home care, oral antipyretics, अब nasal decongestion, तो nasal decongestant we can give, but only the drops. Up to 6 months we can't prescribe, or better to avoid up to 2 years the nasal decongestants. Drops, saline drops are quite good enough. And then the return danger sign should be there. If the child is having intercostal, subcostal retractions, if the child is stopping feed, if child looks dull or cyanosis or pallor, anything you see, then we have to come back. So follow-up is must. So the prescription should have vitals, diagnosis, and follow-up. Now, again, same findings, child feeding adequately. So we would like to admit or manage at home. Again, same. So this child can be managed at home. So what are the indications for hospitalization? So severe pneumonia. So any child which is having retractions and or other findings are there, then we have to admit. Then saturation less than 92%, mild tachypnea, that is 20 plus breath per minute above cutoff. This is very important. And always bradypnea or intermittent apnea, because apnea in medical terminology is considered to be a ominous sign. So intermittent apnea, bradypnea should not be considered normal. अगर मदर कह रही है हिचकी जैसी ले रहा है एंड जस्ट ऑब्जर्व चाइल्ड फॉर 1 to 2 minutes, जस्ट मेक श्योर कि वो हिचकी नहीं हो, दैट कैन बी इंटरमिटेंट एपनिया. Then another important is grunting is very important. Grunting means the child is losing its peep, covering जो है lungs की, that is being destroyed, and the child is not able to maintain the peep. Then family is not able to provide appropriate supervision and care. This is also very important. Compliance. So compliance of the patients in emergency or OPDs, when you just go in the middle of the night at 2 a.m. or 3 a.m., they can't come. If the child is very sick, then that's why the parents are very bothered. So if any child is coming at night, that child should be taken with a pinch of salt. You should have a very corrective step at that stage, that why they have come to this child should be taken well, being addressed well at the OPD or emergency. So then second is compliance. So if the child is living far away from the hospital vicinity, or is approximately 30 to 40 kilometers from any medical facility, so compliance is very poor and they are not able to follow. So follow-up compliance is if restricted, then it's better to admit the child rather than. And then literacy status of the parents is very important. Whether they are able to assess it, whether they are able to feel it about the sickness of the child. And then very important, failure of the OPD treatment. So if the child is not improving by 5th or 6th day, don't take it lightly. And even after the treatment of the 2 to 3 days OPD, if the child is not improving, don't take it lightly. So again, so would you order an X-ray or lab in this child? This is also very important, because sometimes the parents are saying, so they don't want any pricks. Then some of the changes now they are coming, and then they said that we don't want because Googling everyone do the nowadays, sir, is a radiation hota, we will not do the X-ray. So this is very important. Legality is also important here. And then from the treatment perspective, would you order an X-ray or lab with this child? So of course, in this child, there is no need for X-ray, but what are the indications for X-ray? So indications are when diagnostic uncertainty are there. So what is that uncertainty? Suppose child is having fever for 2 to 3 days, tachypnea is there, but crafts are there. Of course, they can be in bronchiolitis, but you see that the child is, both sides are not equal air entry. So unequal air entries findings. Then child is looking sick per se, bronchiolitis जैसा नहीं लग रहा है, because they are happy visas bronchiolitis child. So you feel sickness is there, and diagnostic dilemma is there. This is bronchiolitis. So it's always better when the dilemma is there, go for the investigations. Severe disease is there, severe retraction. So what are the two severe retractions we talk about? So one of the severe retraction is supraesternal retractions. And if any time child is having those retractions, then the second one is head nodding. If any child is having these two symptoms, then the disease is supposed to be the severe. Then another thing is child is not feeding, is vomiting, child is having diaphoresis or cyanosis, pallor is there, or end organ perfusion is compromised due to hypoxia. That is one of the brain. If the child is having uh, altered sensorium or seizures are there, so they are supposed to be the severe disease. Then failure to improve. We have given OPD treatment for 2-3 days and child is not improving, and even worsened fever is continuing. And you, if seen by you in last 2-3 days, and you feel that the coughs are increased and detections are increased and child is looking more dull, suspected complication. You suppose airent is decreased on one side, stony dull, percussion is there, and then recurrent or non-resolving pneumonia. We'll discuss about what is the difference between recurrent pneumonia or non-resolving pneumonia later on. But these are the indications for X-ray. Now, in nutshell, what is the most important in OPD is that the auscultatory findings are not consistent with your diagnosis of less severe etiology. So bronchiolitis, if a child is more towards pneumonia, you will do it, one. And then second, failure to OPD treatment is very important. And then again, so a amalgam of the all the clinical science is more important rather than a single. So clinical features, fever, tachypnea, retractions, refusal to feed, status of the child, and then mother comfort. If mother is saying the child is not well, then it's definitely we have to take it seriously. So just to summarize, when not required, mild uncomplicated pneumonia, you feel that mild tachypnea is there without any danger sign, only fast breathing is there. There is no hypoxia more than 92% and clinically child is stable. More than 94% अगर saturation है, clinically child is stable है, happy है, is feeding well. With mild tachypnea, then you don't have to worry about it. So on all those slides, what are the key learning points? So clinical diagnosis is often sufficient in most of the cases. Pulse oximetry is very critical. This is the fifth vital sign nowadays. Then antibiotic decision is not automatic. You have to just rely on the progress of the disease sometimes and then the clinical condition of the child and social context we have just mentioned. This is very important nowadays. And from a clinician point of view, this is very important that compliance is good or not, and the literacy status of the patient is very important. Now, there are few things. This is, just excuse me. So now coming to the second case. This is an 8-month-old infant presented with history of fever, cough and poor feeding for the 2 days. On examination, it is having a respiratory rate of 62 per minute. That is in chest in drawing and saturation is 88%. So now the question comes, what would be your immediate management steps and oxygen, how and when? What would be the first line antibiotic and do you need investigation before starting the treatment? So how we approach the child with the pneumonia? So immediate management, of course, this child is having hypoxia, start the oxygen, IV antibiotics, supportive care and close monitoring. Then start immediately oxygen if saturation is less than 90% using the nasal prongs and escalate if needed. If you are living in a tertiary center, it's better to go with the ARM. First line antibiotics, they say IV ampicillin plus Zenta or amoxiclav or IV ceftriaxone. But as per local protocol, it's better to use ceftriaxone in our settings because generally well tolerated, well tested, and is easily available also. So I will prefer to use ceftriaxone instead of all those, although amoxiclav is good. Investigations before treatment. So important. Investigation is not the therapeutic measure. So stabilization is very important before starting. So what are the key learning point here? Early recognition of severity saves the life. Most important, oxygen is a priority. Now, if the child is suspected of having severe, because the child is having severe pneumonia, it was having tachy, we can see the respiratory rate is 62 per minute. And then chest, so respiratory rate is 62 per minute, sorry. And chest indrawing is there and saturation is less. So all those features, they just say that the child is having severe pneumonia and should be given IV antibiotic. Oxygen should be given because saturation is less. And minimal investigation. So in this case, what we could have done investigations. One is chest X-ray, another is ABG or VBG, which is easily available. They can be suffice. But if the center is not equipped with the ABG or VBG machine, then CBC and CRPs and X-rays fine enough for the time being. And then pulse oximetry is fifth vital sign that should be done right once. Now coming to the third case, this is a 2-year-old child diagnosed pneumonia. This is very important word, diagnosed pneumonia on antibiotic for 3 days, having persistent fever, respiratory rate is still high. Now there is decreased air entry on the left side. We have all discussed all those things that auscultation is very important at this stage of time. The child is not moving. So what is diagnosis now? The one is pleural effusion because the child is having decreased air entry, then foreign body aspiration, pneumothorax, and tuberculosis. These are the 4 things which comes in mind if the child is having fever for the prolonged duration. So is this treatment failure or wrong diagnosis? One. And when to repeat the chest X-ray? Second one. And when to suspect the complication of the pneumonia? So of course, this child fits in the non-response pneumonia because the child has received antibiotic for the 2 days. So this is a complication. Now this is the repeat X-ray. Now you can see all the DNB students which are just listening. The best is we have to just divide in the zones, so upper, middle, and lower zones. And the most of the zones, they are occupied or pacified. We can't just see the aerated lungs here. Now the costophrenic angle, this is obliterated. And of course, the cardiac chill out is also not visible. So this must be some pneumonia, or we can say some other complication which is just there. So what is that complication? You just have got my point now. So this is clinical worsening. So when to order the repeat X-ray? So if there is no clinical improvement after 2 to 3 days of antibiotics, there is clinical worsening, there is increasing respiratory rate, and then asymmetry on examination. Already mentioned, these are very few things which are very important. So clinical diagnosis is very important, and then the clinical findings are one of the most important in pediatric population because more or less we are treating the one of the veterinary type of medical facility that they don't say much about the symptoms as such. So we have to just rely on the signs or the clinical findings we can just gather from the patient and suspected complications. If there are, in this case, we have seen because the child is having decreased air entry on the left side, so repeat X-ray is needed. And when to suspect the complications. So high fever persistent more than 3 days despite good antibiotics and good dose. This is very important. Good antibiotics with good dose. If the child is receiving cefixime for the respiratory tract infection is not a good choice per se. If the child is toxic low, sick child. So the most important thing I just want to mention is consolable or not. One. And if the child is irritable in the mother's lap, these are the two things which are very important. Then increasing respiratory distress, chest pain, and unilateral decreased air. So these are the complications. The most important complications are empyema and then pneumothorax. So what would be the next investigation? Question comes, would you want to change the antibiotics and how do you manage this case? So child who is worsening despite the oral antibiotics for the past 3 days and is having decreased air entry on the left side. So how do you manage this case? So you can see the USG here and we can clearly see the septations here. So pleural effusion is there with septations. So this is the simple pleural effusion and this is the septate pleural effusion, located pleural effusion. So now coming to the pneumonia with effusion of the X-ray. So if small effusion is there and there is no respiratory distress, although there is standard textbook, they don't mention about the small or large effusion. They have no grading system for that. But more or less, they say small effusion is less than 1/3 of the uh, pulmonary cell out is filled with the water. So small effusion, no respiratory distress, go for the antibiotics. If modified large effusion, modified means loculated or those with respiratory distress, USG we have to do. And then simple effusion, not loculated. If simple effusion is there, no loculations on ultrasonography, go with the intercostal drainage with antibiotics. And these antibiotics should be for the coverage of the staphylococcus. Complicated effusion, loculated and ecogenic, then fibrinolytics should be given. And if you go for the BTS guidelines, then they say that if large effusion is there, it's better to go for the fibrinolytics because the studies have shown that they used to decrease the length of the stay. So ICD plus antibiotic failure or progression. So if the now coming back to the effusion with X-ray, if small effusion is there and there is no improvement in 48 hours or worsening, repeat chest X-ray, effusion is increased or the respiratory distress. So again, same thing. Agar if effusion has increased or respiratory distress is present, then again go for the ICD plus antibiotics. And if the loculated effusion is there, then we have to go for the fibrinolytic. And then if persistent despite all those things, so that's it. So just to summarize, if child is having effusion and is small, so initially we have to give antibiotics for 48 hours. And if the child is improving, then they continue with the antibiotic. Repeat X-ray is not worsening. If the child is worsening per se, or the effusion has increased in the repeat X-ray, then we have to go for the ICD insertion. And if the loculations are there, then we have to go with the fibrinolytics. And fibrinolytics of choice are generally urokinase and streptokinase are there. Drug of choice is urokinase, but it's less available. And nowadays, I think most of the places it's extinct now. So the only left is streptokinase, although other teplase and all those things are there, but they are very costly. So urokinase and streptokinase, the dose of the urokinase is 10,000 for less than 10 kg and 40,000 for more than 10 kg. 10 ml and 40 ml subsequently they have to in less than 10 kg 10 ml and more than 10 kg 40 ml for 4 hours dwell time. And streptokinase is 50,000 unit per kg twice a day, and this is given for 3 days. So the dwell time for those is around 4 hours. It is said that the bleeding tendency is there. They used to have, but most of the time it is seen that just the tinge of the blood is there in the aspiration, which is coming through the ICD. But generally, the more bleeding tendencies, they are not seen in the pediatric population per se, in my experience. And I've seen shared with others also. The books also don't mention about the more complication in the pediatric population. So key learning point here is always reassess the diagnosis, look for the complications early, avoid blind antibiotic escalation, and imaging becomes important here if the child is having worsening of the system. Now coming to the fourth case, this is 3 years old child, history of cough for the 4 week, fever for the past 4 week, and respiratory difficulty for the past 4 weeks. So the symptoms are prolonged hair, chronic hair. On examination, child is having tachypnea and air entry is decreased on the left side. So child has received antibiotics from the local practitioner, then admitted in the private hospital and received 2 weeks antibiotic with no response. So what is thought process now and what is the next investigation? So this is a case of pneumonia which is prolonged. So important thing is having tachypnea and then air entry is decreased on the left side and symptoms are persistent now. Now see the X-ray. So in the X-ray, there is clear-cut shifting of the this mediastinum to the right side. So lots of investigations were treated with antibiotic. What the most important two things is missed. One is 3 years age, and then the history is not mentioned about acute onset of cough symptoms. So always ask about the when the cough was started. If they say that the child was having peanut or child was just eating the gram or anything else or was just blowing CT or anything extra visuals. So that has to be taken very seriously about the history now. So when the bronchoscopy was done, we can clearly see the right side is clear enough, and on the left side we can just see is full with fluid, and this we can see the obliteration of the lumen. And what we have seen, this is the foreign body which was removed. So the important thing here is that one, history taking, second, clinical examination, and third is the investigation which has been done earlier also. So this is a clear cut. There is shifting of the mediastinum, and the child, when just history was reviewed, it was said that they were history of the sorry, this was peanut, and there was history of eating peanut. So this is not mucus, this is peanut, and this is more organized now. Now coming to the another case, 4-month male infant is resident of Rajasthan, one of the city of Rajasthan. Chief complaints: recurrent cough for the 3 months and difficult breathing for the past 2 months, and history of poor weight gain is there. So now this is having three or important things. One is age, second is recurrent cough, and there is history of the poor weight gain. This is very important history when we are dealing with a chronic patient. So on examination, the child has a tachypnea, subcostal and intercostal detections were there. Saturation was 85% on the room air. Respiratory system, child was having bilateral clefts on auscultation. CS, no findings were there. No focal deficits in CNS, and abdomen is soft. There is no organomegaly. Now see, the pneumonia is there, was on the bilateral sides, and we can see child was intubated also. So these are the findings. We can see the X-rays, both the lung are involved. These are opacification of both the lungs, and serial X-ray is also showing the same finding. So this is mainly what we can say persistent pneumonia rather than the recurrent pneumonias. So diagnosis here is can be aspiration, can be cystic fibrosis, it can be immunodeficiency and the congenital lung inflammation. So what are the clinical concerns here and what is the differential diagnosis? So persistent pneumonia, recurrent pneumonia is there. So what is the clinical condition which saying that this child is not normal? We have to just go for the another diagnosis now. Is that What are the key clinical concerns here? Chronic respiratory symptoms since early infancy, 1, then failure to thrive, 2, hypoxia, 3rd, and bilateral crepitation. So this is more so of the persistent pneumonia with hypoxemia, failure to thrive, and chronic, of course, this is presentation. So DD can be airway clearance defects, can be immunodeficiency, can be congenital malformation, and the aspiration syndromes. So this is the investigation. The child was done. PS is 7.56. And the another thing is that chloride is 86, sodium is low, potassium is low, chloride is low, and alkalosis is there. So this is a typical finding of ABG of any patient. So you must have just got what it can be. So other workup, today echo is normal, USG whole abdomen normal study, and USG whole abdomen, normal. Other report aquagenic wrinkling test positive at 2 times, sweat chloride test was done, it showed high sweat chloride and stool for folliculoplasia positive. So this is a case of cystic fibrosis. So what is a simplified algorithm for case of cystic fibrosis? When a child is presented with recurrent or persistent pneumonia, malabsorption, failure to thrive, sputum and Krebs swab, culture positive for Pseudomonas or Burkhardt-Doria cepacia. If yes, then make a diagnosis of CF and start the treatment and confirm diagnosis later with swab test abnormal mutations. But if these are not positive, then score for sibling history with CF, 2 points, stool positive for fat globulus 2, clubbing 1.5, hyponatremia 1, metabolic alkalosis 1, and positive echogenic wrinkling with 3 minutes 2. So total score if more than 2.5 is consistent with the cystic fibrosis. So now question comes at how you diagnose recurrent and persistent and how you label it. So the most important is if there is radiographic clearance or X-ray clearance is there, then it is said to be the recurrent. And if there is no radiographic clearance, the X-ray कभी normal हुए ही नहीं है, they were always abnormal, that is supposed to be the persistent. And now coming to the recurrent, if the child is having more than 2 symptoms in 1 year of the pneumonia and more than 3 in life in any point of time. So 3 बार से pneumonia से अगर वो admit हो गया है, then that falls in the category of the recurrent pneumonia. So how we go through it? So if the child is having unilobal pneumonia or one lobe is affected, then always go for it. If the pneumonia is unilobar, then bronchoscopy should be done. If not being done at our center, then it's better to refer to a center where this is done, because unilobar pneumonia and recurrent or persistent pneumonia is not a normal finding. It can be anything with foreign body or some congenital abnormality. If normal bronchoscopy, then go for the CT chest. If it's multinovar pneumonia, then you can think of recurrent pneumonia with normal immunity, go for the immunity workup. So if normal immunity and with the immunodeficiency, it can be congenital or acquired immunodeficiency. So always go for, it can be aspiration, go for the history, Sandifer syndrome के features आ रहे हैं, the child is having extension, then that can be aspiration. Then history again is very important of the asthma and allergy, atopy in the child, atopy in the family history, and then recurrent symptom with wheezing, with weather change. So there should be some confounding factors and then risk factors and then trigger factors. So all those things we have to just go for in asthma and allergy. And the most important another thing in clinical practice is if the child is having a good response to the beta 2 agonist, then it goes more in favor of the asthma rather than other diagnosis. So even in bronchiolitis, beta 2 agonists are recommended, or we can say wheezing is the predominant system, just go for the beta 2 agonist nebulization. Then cardiovascular shunt and mucociliary clearance defect, just like ciliary dyskinesias. Now, coming to the another case, this is a 5 years male child resident of the Nagaur, again in from Rajasthan, with chief complaint of fever for the past 10 days, cough for past 10 days, having difficulty in the breathing, and then lethargy with paleness of the body for the 10 days, with recurrent similar episode since 3 years of the age. So again, we are dealing with a chronic symptomatology, recurrent pictures. So what is the past history? We have to just recapitulate this. First episode at 3 years of age, was admitted in hospital for around 10 days, given oxygen supplementation, IV medication, red blood transfusion, and discharge on oral medication. So most important here, we have to just see treatment history is very important. कि उसको red blood transfusion मिला है या नहीं. Then second episode at 3.5 years of age, same complaint, admitted for few days and received respiratory support, red blood cell transfusion, and IV medication, followed by 4 to 5 episodes per year. So if the child is having, so the child is having recurrent episodes. Then now this is the third current episode, admitted outside for respiratory failure and severe anemia. Received IV antibiotic, red blood transfusion again, and oxygen support and embolization. Referred in view of persistent respiratory distress. So you must have just thought in your mind what it can be. So we will. So in the examination, tachycardia is there, tachypnea is there, saturation is 80% on the room air, required SFNC support. There are bilateral diffuse crepitus, liver is 4 centimeter, and the clubbing is grade 2. So child is having chronic hypoxic symptoms. Hepatomegaly is there. Bilateral diffuse crepitus is there, means pneumonia is there, hypoxia is there, and distress is having severe pneumonia, but this is a case of persistent or recurrent pneumonia. So now coming to the X-rays, you can just see bilateral again, opacification again in the both the lungs and almost in all the fields. All the fields are having pneumonia, opacification. So what is interpretation? What is the DD? And what is the next line of investigation? Of course, these are the things which comes in our mind. Child is having all the symptoms of the severe pneumonia and recurrent episodes are there. So these were the initial investigations. We came across having anemia, hemoglobin of 5.5, platelets are fine. Then retics are increased 6.6%. So means body is making hemoglobin at the robust rate. Iron is less, ferritin is very increased, DCT is negative, so this is not the hemolytic anemia. 2D echo is normal, so we are not dealing with the cyanotic heart disease. We have seen this for the cyanotic or hypoxic episodes that it can be. So we have all gone through, and then anti-TTG is negative, so this is not celiac. Then IgE, that was also normal. IDS, so not increased, means hemolysis is there. And from autoimmune point of view, ANCA, CNCA, and PNCA, they are also normal. Urine is normal. Child is negative for the hepatotropic viruses. HIV is also negative. So we have ruled out everything which can lead to the anemia. And now the CT scan, almost all the lung fluids are involved. Pneumonia is there, but not as such anything specific about this. And then bronchoscopic ball is seen. And now we can just clearly see that the ball is showing RBCs. And when negative for the gram stain, culture was also tried. And when the pulse Prussian blue staining was done, they were seen hemosiderin-laden alveolar macrophages 80%. So they are. This is one of the most important finding we can see, more than 80% is a not a normal. And past stain did not highlight any fungal. So for chronic pneumonias, for the recurrent or persistent pneumonia, we have to just go for this also because they can be in the fungal pneumonias also in post-COVID state we have seen in adolescent or adults, but in not in the pediatric population. And wall fluid for cytological examination, we have seen findings above. So macrophages more than 80%. So what are the differential diagnosis here? Idiopathic pulmonary hemosiderosis, idiopathic pulmonary hypertension secondary to the bronchopulmonary dysplasia. This so history of prematurity should be taken in account. It can be in iron deficiency anemia. It can be in recurrent infections. It can be in systemic onset juvenile idiopathic arthritis, and in the macrophage activation syndrome. These findings can be there. But generally in Sogia or mass anemia is of not much intensity. Then coming one by one, DD, if you rule out idiopathic pulmonary hypertension secondary to BPD, so again, history of prematurity should be taken. And then the bowel fluid in these generally do not have more than 20% of the macrophages. Iron deficiency anemia, we can see all those findings, but generally these macrophage, hemosiderin-laden macrophages, they are not of the same aptitude in these. Again, more than 20% also not possible. Recurrent infection can have hemoptysis, but not to this extent, and all these things. So the diagnosis sometimes in repeated blood transfusion, such like thalassemia or other patient, they can have these findings, but again, the hemosiderin-laden macrophages, they are less than generally 20%, 30% in these cases. If more than that, that goes in favor of the idiopathic pulmonary hemosiderosis. So now we have seen all those things. So the key point again, we have to see that the history, clinical examination, and then treat the life-endangering situations first and then go for the investigation. So key learning point here, recurrent repeated infections alone should be taken very seriously. If recurrent or persistent is there, then always look for the underlying cause. And structured evaluation is very essential at the end. So from all those things, the take-home message is clinical judgment is having priority always for the investigations. Pulse oximetry is very essential. This is one of the most important vital sign now. It is, that is fifth vital sign. All pneumonia do not need antibiotics. So when we are sitting in the emergency or in the OPDs, we have to just see or just differentiate that what is just an acute viral illness versus bacterial versus worsening condition. So early identification of severity is very critical. And then non-response requires rethinking the diagnosis. This is very important. The child is not responding to the treatment. Rethink, reevaluate, PET triangles comes and evaluate, identify, and intervene at this stage. Thanks. Any questions are most welcome. Hello.
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 If they are, hello,
Ans-
can you hear me, Dr. Sunil?
Yeah.
Let me see if there are any questions in the chat box. You
Okay,
can
sir.
take up those questions.
I think all either they are just very wise enough that they have.
Let me see. Tachypnea without, this is the question. Tachypnea without pneumonia in septic shock child. This was a question which was asked by you, I think.
By me?
No.
No, I
Tachypnea
don't.
without pneumonia in septic shock child. This is what the person is asking.
So I can answer it if
Yeah, please.
someone is asking. So tachypnea without pneumonia in septic child.
Right.
Yeah. So this another just we have missed this point earlier also. So if the child is having tachypnea, so other diagnosis other than pneumonia, what can they be? So that can be seen in acidosis. That can be seen in intracranial hemorrhage. The child can have tachypnea. And that can be seen in many metabolic diseases also. So in septic shock, generally they have the metabolic acidosis because of the poor perfusion, and that's why they are having tachypnea. So this is the metabolic acidosis per se. That's why they are having tachypnea in the child.
But there is one more question, Dr. Sunil. What amount of fluid in ultrasound is a moderate requiring ICD?
So again, I mentioned this. This is not clear. Nowhere it is written in the standard textbook. But ICD drainage should be done if half of the lung field are opacified. अगर half lung में है, then it should be drained with the ICD SS. That's the only thing that is written. But as such, moderate effusion they describe, but per se in pediatric textbook, they have not mentioned about the mild, moderate, or severe effusion. It's effusion. It can be minimal or massive.
So regarding this drainage, Dr. Sunil has very well clarified, right? So this amount, there is no single amount, because if for a small child, even a 50 ml can be moderate. And for a larger child, 50 can be very minimal. It depends on the child size also.
Size also.
And second, how toxic is the child actually? How sick is the child? How thick is the fluid? So many points are taken into consideration in
So
addition to quantity.
yeah, so that's why the diagnostic, so suppose intracostal drainage sometimes can be very important here. So we just go for the diagnostic needle aspiration and then go for it.
Then somebody asked, sir, can you please brief the diagnostic algorithm of case 6 in a short
Diagnostic.
algorithm? We can go to the case 6, Doctor.
Okay. Yeah.
Just see actually what is the query he's asking for.
So now we will go through this diagnostic algorithm for the this. So this is a case of uh, uh, persistent or recurrent pneumonia first. Then second, now just we will go for the this one. So this is multilobar pneumonia, recurrent pneumonia, and with recurrent pneumonia with normal immunity generally, where the child was evaluated for the immunodeficiency and was found normal for that. So generally these are the four things which I have seen: aspiration, asthma, CV scent, and mucociliary defect. But if they are there, then we have to just see for the CT also. So we have done with the CT chest in that case, and on CT the pneumonia was found. And so again, I'm saying it's not about algorithm alone. It's about you found some pneumonia which is non-resolving, multilobar. So you have to rule out the immunodeficiency, and then if there is no immunodeficiency, then you have to rule out all those things. So all investigation has to be done. CV shunts, echo was normal. There was no history with asthma allergy. Then there was no history of aspiration, and per se, the child was not having any sign of mucociliary clearance defect also. No, so the diagnosis left was something is there, recurrent pneumonia, which is affecting the red cells also. So this child had anemia with pneumonia and then with hemoptysis. So the diagnosis left is, now we can see these are the few DDs we have left with: idiopathic pulmonary hemosidosis, idiopathic pulmonary hypertension. Secondary to BPT, the child was not having prematurity, iron deficiency anemia, perhaps because the that The ABC, they were normal. Recurrent infections per se were not identified earlier also, and PNK and CNK, they were normal in this case. So the diagnosis left was idiopathic pulmonary hemosiderosis, and the investigations were also in the favor of the same.
I think there was one more question.
Hmm.
Sir, when to give DEXA?
When to give DEXA? Okay, so first, what are the conditions in which can be given dexamethasone? What are the conditions should be not be given with the dexamethasone? So if the child is having pneumonia and having fever and all goes in favor of the lobar pneumonia or multilobar pneumonia, dexamethasone is not given. Now, second choice is that the confusion is mainly with the bronchiolitis or asthma. So in that case, if the child is having fever with all the features which are sensitive, severe pneumonia with dullness, retractions, crabs, and all those things, and reduced entry on any side. So they are more of the pneumonia per se or the parenchymal disease. Again, dexamethasone is not recommended. Now coming third to the bronchiolitis, again the books are saying steroid are not recommended in bronchiolitis. So the fourth condition which stands at one for the respiratory is the asthma. So if history of atopy is there, first, then recurrent episodes are there, second, good response to bronchodilators, third, and family history is there, fourth. These are the few things which are there. The child is, and then wheezing is there. And you have done the X-ray, which is normal. So this is the condition where the steroids can be given. And the second thing where the steroids can be given is septic shock, but that is secondary thing. If the child is in septic shock along with pneumonia, in that stage, we can give the steroids.
Can somebody ask, can we directly refer to VETs rather than starting fibrinolytic and ICD, etc.?
Yeah, yeah. So this is now primary VETs for secondary VETs. This is the condition when we say that when the primary VETs and secondary VETs. So secondary VETs, if the failure of the fibrinolytic is there, then the we can go through for the primary VETs directly also. So what are the conditions where we should go? So if the pleural thickening is there, one, and then second, if the child has pneumonia. So the important finding here is that we go for the USG and pleural thickening is there and organized is there first, then go for the primary VET. This is the only direct indication for the primary VETs, pleural thickening with the organized pus, where the primary VETs is recommended straightforwardly.
Thank you, Dr. Sunil.
Thank you, sir. So nice of you.
I think there are few more questions because the time is limited. We will not be able to answer all the questions.
So
The number of questions
direct
shows it was a very, very interesting and useful topic for all of the candidates and delegates.
So what we can do, Gaurav, just you can send them my number and they can just ask on WhatsApp if they feel. It's my honor, it's my good that I will feel privileged to give them some clue for their question.
Do you want to answer the question, Dr. Sunil, right now?
I can,
You can do it,
yeah, I can.
Achha,
Yeah.
okay. I thought this time is the limitation. You can just see
No,
the
no,
answer. You can see the question in the chat box.
Okay, in the chat box.
Right.
So,
Their
but
last
no,
two questions are there.
not visible to me. Okay, sorry.
Question and answer.
Okay.
Are you able to find out?
Yes, sir. Sir, when to give DEXA?
And this has been answered.
Yeah.
Now,
Now some guidance to how to read patchy consolidation on a chest X-ray. So I'm not getting what he wants to ask about, but let me. I think I can just give glimpse of what he wants to ask. So how to read patchy consolidation? So we divide the chest into three zones: upper, mid, and lower zones radiographically. So up to second rib, then sorry, fourth rib, then fourth to eighth rib, and below that, they are considered as if upper, middle, and lower zones, and we just describe as a zone only when we are reading the X-ray on the uh, reading the X-ray. So now I think we are clear. So we have to read upper, middle, and lower and label that as a pneumonia of the upper lobe, pneumonia of the middle zone, or lower zone. So we don't mention here lobes, we mention only the zones. Now, second is another question. Can we directly refer to WETs rather than static fibrinolytic and ICD? I've answered this. Uh, so sudden onset moderate pleural effusion in 11-year-old child, sickle cell trait child. Is it pulmonary TB until proven otherwise? CB net for pleural effusion is negative. Should we start ATT when antibiotic response is poor? Now this is another question. Generally, in pleural effusions, we are not getting CB-net positive, so yield is not more than 20-30% generally. Even so, of course, before starting ATT, we should go for the diagnostic modalities which are available. So we can go for the gastric aspirates, and in the morning aspirates, or since this is a 11 or old child, so we can go for the sputum also, induced sputum. So by the nebulization with the 3% NaCl or N-acetylcysteine sometimes may help. So of course we have to, and then this is a 11-year-old child. Of course, the tuberculin test is not going to be a good measure, but a combination of all those investigations should be used. So CB-net in pleural fluid is negative, but we should go for the uh, gastric aspirate or induced sputum. Then second can be uh, TB gold, although not a great test, but all those investigations should be done. And if anything is positive, then we can do. But before starting antibiotics, sorry, ATT in this child, we have to rule out all other things also, which we have earlier mentioned. So in this child, since uh, more, this is a sickle cell trait, so more goes in favor of TB. But I'm not uh, convinced with the TB diagnosis right now, if they are mentioning. So again, you can go for the pleural effusion and other tests also in that effusion. What is the LDS status? What is the pH of the fluid? What is the protein status, and what is the glucose? So all those things, if they go in favor of the tuberculous effusion, then of course we can think of giving ATT. But before putting diagnosis, I'm not a good fan of ATT as such. So please share numbers here. Hello.
please share the number. Definitely. No issue.
Okay, sir. So,
Okay. It's
can I?
always better that they have got such a good teacher. They want to ask so many questions, right?
Mhm. Okay, sir. So nice
So,
of you, sir. It was a good
okay.
discussion all together, and again, I'm seeing nostalgic feeling always.
Right. So, Dr. Smith, thank you so much. And I'm surprised that in just 1 hour, you have given us a very broad overview and all the details of that topic, which is very, very useful to the DNB students, and given them practical solutions and discuss the real case scenarios also. And you have included lots of false algorithm while managing the child. That was great. That was great. So thank you so much once again to all the participants. for participating in this DNB class. Thank you.
Okay, sir. So nice of you, sir.
Okay, thank you, Dr. Sunil, once again.
Thank you, sir. Thank you, sir.